Greetings everyone and welcome to the 62nd session of the online Optom learning series, OOLS. So let me introduce to you our speaker for today's session. So today we have Dr. Maria Sampalis. Dr. Maria is a graduate from the New England College of Optometry. She finished her optometry studies in the year 2007. And she is a founder of the very famous Facebook page, which is Corporate Optometry. I think there are about 29.5 thousand optometrists in that group, a very vast group where, there is a lot of knowledge sharing happening in that Facebook group. We are sharing the link to the Facebook group onto the chat now. If you wish to visit that Facebook group and if you want to join in, please feel free to do so. And today, Dr. Maria is going to talk to us about medical optometry. How do we extend the optometric services beyond just refractive care? So welcome, Dr. Maria, and thank you for taking up this time and speaking to the audience today. And let me leave the screen time to you now.
Yeah, thank you so much for having me. It's an honor to talk to optometrists all over the world. Besides just, Facebook messaging and emails like I do within the group. So, and just, trying to help expand optometry throughout the world. I know each country has different rules, and one of the big things in the group is trying to get optometrists together to expand scope. So I think that's important. Medical optometry, extending beyond refractive care. So I think the medical optometry is the future of optometry. Okay, each country is a little different, but here in the United States, we have a lot of insurance plans, a lot of vision plans that dictate routine exams. We have consolidation in the industry. We've seen SLR merge with Luxottica. We've seen almost in the future looking to purchase Grand Vision, and coming into one company, and that changes the future of optometry. We've had a lot of online eye exams, glasses online, a lot more competition, people not in the industry trying to, sell blue blocking glasses and other things, and then decrease reimbursements from insurance companies. So this is one way to combat that, is kind of expanding your scope, because we, in this country here, we have the full scope to do a lot in optometry, and other countries as well. We just haven't kind of broken that common path that we've done beyond refractive care. And I think now's the time to really embrace the medical model. So evolving your practice model will increase profitability and revenue stream within the practice. You'll find what I say is hidden revenue in a practice without bringing on new patients, in a sense, is just, taking those patients and increasing the per patient transaction, but also, helping, retain those patients and kind of, keeping them in your practice from all the distractions out there that they have in all the other avenues that they have for eye care. So embracing the medical model in the practice, one way to do it is through patient education. Obviously, there is some diagnostic equipment that needs to be purchased for the treatment of diseases, but it'll increase your patient retention and the revenue. If you look at dry eye, which is not a big investment in a practice, a large population report it's almost about 3.2 million people have dry eye. And a lot of optometrists dismiss it and say, just get artificial tears. But following up in your practice, giving them education, reassuring them on, treatment methods that we'll go into a little more, will help, grow that. And then they trust you and they refer patients, and they're stuck to your practice. The other thing is communication. So to provide a higher level of care and grow your business, I advocate is embracing the medical model. The first step is, appropriate classification for each patient prior to the exam, kind of understanding, what they're asking for in their chief complaint, what they're looking for in an exam besides just glasses. And, making sure that they understand that an eye exam is not just a prescription change, that it's a lot more, especially as they get older, if they have family history, or any other diseases. So communication is important. It starts in your exam chair. The doctor needs to communicate with each patient, their specific treatment and what they're looking for towards the future to keep those patients as well. So going medical here in the U.S., because there's a lot of insurances, and I'm sure there's guidelines in different countries as well, we determine the level of exam, medical versus vision, by the chief complaint. So if the patient comes in, they have blurry vision, we'll do an exam, and we'll notice that they're cataracts, so that's a medical visit instead of a refractive visit in a sense, or routine. We'll educate the patient, and then my diagnosis and treatment plan will be documented properly in the chart. Each step in the exam is done, and the patient is documented in the follow-up care. So if it's like +1, usually I have them come back in a year. If it's a little more coming close here in the U.S., it's to be best corrected 2040 to have cataract surgery, then we have it back sooner and be able to monitor the patient and then refer to a cataract surgeon, but also do the follow-up pre and post-op with the surgeon. So the medical model is, patient-centric. So, and then you're dilating eye exams, dilating the patients. It's the problem-focused exams. The therapeutics and treatment strategies. Contact lenses can be medical model too, and we'll go into that as well. And then, doctor-driven dispensing. So incorporating the refractive. So if a patient has cataracts, we recommend anti-reflective coating because you're getting a lot of glare. That's coming from the cataract, and you incorporate back into, the eye exam. So here is some information from NIH, and basically it just shows that the patient has different, healthcare providers, and you should be part of that network. So you should be, sending referral letters out to their physicians and other healthcare professionals. So if they're diabetics, their primary care, their endocrinologist. We have, like in my office, a letter that we send out, and it's pretty standard, and we get it out, but it also gets referrals back. And so the MDs will send new patients to us, and it'll grow our practice. So again, just a little refresher here. It's, medical versus vision. So it's based on chief complaint. And then we find the diagnosis and the treatment. We do a follow-up. And then fees are a little different here in the U.S. Routine eye exams are one fee, but, the medical has to be standard throughout. So it's not the same as routine here, and you have to monitor it for insurance audits and things like that. So therapeutic and strategies. So you can look into ocular surface disease. Optometrists should be controlling the dry eye. We should be the first people patients think of as optometrists for dry eye. A lot of different countries, depending on what they can do. We can treat glaucoma here in the U.S. Each state's a little different. I practice in Rhode Island, but I also have a Massachusetts license. Unfortunately, right now, Massachusetts is not allowed to treat for glaucoma. We are advocating for that. So that in Rhode Island, my practice, we have a visual field, OCT, and we screen for glaucoma suspects and treat glaucoma as well. Retinal disease and macular degeneration, which is, I think, going to be more prevalent over the next, 20 to 30 years as well. So with contact lenses, a lot of people think it's a refractive thing, but if we take thinking about it as a medical model, specialized testing, we'll see that, corneal topography, pachymetry, endothelial cell count, anterior segment photography, and dry eye testing. That's important. You're taking all those into consideration. You're talking to the patient about, overwearing contact lenses, possible risk for infections. They need to be educated that, even if their eyes feel uncomfortable, there are solutions to it with dry eye, and there are other contact lenses. And, try to make it, the communication be appropriate so the patient understands. With here in the U.S., there are other online contact lens vendors like Hubble and things like that. and they're not properly fit. I know each country has different rules, but having the patients understand that it's not just a cosmetic or just like a routine thing that they can just get anywhere, that there is measurements and specialty instructions that they need to follow, and it's fitted to them. It's a custom thing for their eyes, and again, it goes back to the practitioner and explaining that to the patient. And then these things as well, which a lot of doctors will look at but maybe not communicate to the patient. So overwearing contact lenses, early neovascularization, dry eye symptoms. They say, "Oh, doc, I'm fine. I'm just here for my RX. I ran out of contacts." Asking those questions about dry eye, maybe about the solutions that they use, and giving them new options. I've seen some patients come from other offices and they're still wearing, maybe like AccuView 2s. There are latest technology out there. Why not update the patients? And better, tear film, better oxygen to the eye. Some contact lenses have UV blockers, things like that, and just educate them on why, you're upgrading them. And, I think patients appreciate that. They want to know what's the latest out there. So just like they're looking for the latest iPhone or things like that, they want the latest contact lenses. Their eyes are important. You're their professional. Educate them on it. Treatment of contact lenses, complications as well, infections, ulcers, things like that. Let the patients know that they need to come see you. I've had a lot of patients with like pink eye and they go to the emergency room. Let the patients know that you are the expert for them to see. And then we have the specialty contact lenses, obviously, sclerals, we have gas permeables, multifocals. There's a lot now with CooperVision here in the US came out with MySight is myopia management. And I think that will be a great campaign to kind of reduce myopia, the prevalence of it here. So there's a lot of things, and that's more medical, and it's just getting the mentality to say, oh, these are daily lenses. They're not really medical. They are. So it's just, again, educating the patient. That's important. So doctor-driven dispensing, doctors would say, they need progressives and hand it off to the optician. I think it here as the medical model here, there are products that benefit your patients that are just, beyond refractive care. So patient has a family history of AMD, you might recommend polarized sunglasses, you might recommend transition lenses. If they have dry eye or again AMD, you might recommend nutraceuticals. And then, antireflective coating now with cataracts patients, and just correlate it back to the issue that they have, so they understand, that it's not just a routine exam, that it goes back to what happened. It's a custom product for them. And now with the COVID, there's been a lot of computer vision syndrome and things like that. A lot more patients looking for blue light filters and things like that. Explain to them why the products that you have in your office are better than online. So, and what they do. I mean, the studies are still out there for blue light, but, let them know, say, this is not 100% yet, but, it's looking that it could lead to macular degeneration. We have the products here to protect your eyes. I'm going to be seeing you for the next 30 years or so. I want to make sure that your eyes are protected. So this is the same thing here. We let patients know that sunglasses are more than just prescribing. It's a medical standpoint, more to protect their eyes. And I think we've seen over the years, patients understand that and wear sunglasses. So some action points, because it is hard to get started once you're in a regular routine. Obviously, you have to train your staff. There is, some investment in diagnostic equipment. You have to review pre-test protocols, schedule follow-up visits, monitor your fees on that, and perform a chart audit. If insurances, you're billing insurances, you have to follow the rules. So you want to make sure that you performed each step in the exam that qualifies for that level of care. So if an insurance comes, and they audit you, that you're prepared for it. And it's just educating yourself, and we are perfectly capable as optometrists to perform the highest level of care for medical model in our practices. We just need to become more familiar with it. So, staff training is important. They need to be on board. They need to be identify with patients' reasons for the visit. I have my receptionist screen on the phone. What are you coming in for? I have dry eye. So they come in, we do a dry eye workup. We tell them we can't do a refractive exam until that, we solve the issue. And then we'll do a follow-up visit. And if things are fine, then we'll continue with, a routine exam. Or sometimes we do a routine exam, we find something and have them come back. There's a lot of things that we can do in our in-house, in our offices, and follow up instead of referring out. So diagnostic equipment's important. Obviously, they can go in different layers. You don't have to big investment. I think starting off is good with retinal photography, and then visual field, and then you can go from there as your clinic grows. So here's an image of an OCT. And then reviewing pre-test protocols, I think that's important as well. So it doesn't increase chair time. It doesn't take more time away from your patients. It actually takes less because they're problem-focused exams. So the patient is coming in for specific. You're checking their IOP because you put them on drops. You're expecting, let's say, 30% drop in their pressures after 4 or 5 weeks, and it's a quick visit. If your techs are savvy and you train them properly and they understand, then they know what they're looking for. And then you come in and you just review it, and then you do your follow up, what they're going to see them for, what the next testing is. And once you get comfortable, what your strategy is. If you're going to see somebody every 3 months, every 6 months, every year, which one's high risk, which one's low, and you'll become comfortable. And it's just regular staff meetings and having patients, your staff understand this. And it doesn't take a long time. It might be like a 15-minute huddle before you start seeing patients on maybe a Tuesday, or you buy lunch and you talk about it, and just making sure people are all on the same page. Something that might be simple to you might not be simple for someone else. So just asking questions and see what you can, what they understand, and what sometimes you don't know what patients are thinking. They deal with patients front desk all the time, and they'll tell them different things than what they tell the doctor. So that's good information for you to know, to kind of make it easier and for the patient to understand too, especially when it comes here in the U.S. between vision plans and medical. So, well, my medical says I have a diabetic eye. My vision plan says I have a diabetic eye exam. It does, sir, but you have diabetic retinopathy, and it really goes under your medical insurance. And these are your retinal photos, and this is what a normal diabetic retina looks like, and that's important, so they understand as well. And then you have the follow-up visits. You're scheduling them. It can be, what I've done for effective scheduling is, if they're short visits, if it'd be like non-peak hours. Here we have clinics, like Saturdays are pretty busy, afternoons are pretty busy. I try to schedule, the follow-ups. My Medicare patients are older, they're retired, trying to do it non-peak visits. And now with COVID too, those patients are higher risk, and we can't see as many patients per hour. So that has been something for scheduling, has been important. And then like the testing, if you train your staff properly, the visual field, the OCT can be done, when you're seeing a routine exam, or maybe during a lunch break for yourself, because you're just reviewing it and you're going in and explaining the testing. So, to keep in mind that, it doesn't take up a lot of chair time, and something like this can really benefit your practice, even besides just revenue, just trust, referrals, and retention. Sometimes if you have patients that can't be, come back for a follow-up visit, sometimes in a lot of retail clinics, you get patients that, are kind of there for a short period of time. They're visiting the area, but you want to have this testing just for, so you can send them back out to a doctor in their area, or just to make sure you have a proper clinical record, just to show that, you did what you're supposed to be doing and the patient didn't follow up. You can do same day testing. Some things are dictated by insurance on what you can and can't do. But yeah, sometimes do an exam. We notice that their cups are large, and we'll do a visual field and a retinal camera that day. So, the fees, we monitor fees here. That's important. And we also take some business metrics per patient transaction. And that's important to kind of see where you stand in the practice and, how it's working, right? Because if you grow, you might have to add new diagnostic equipment or hire more staff. So you have to understand if it makes sense, right? So average transaction is total visit fees collected divided by the number of patients. And then obviously we perform a chart audit. That's important. So again, you have to know the rules for the insurances and follow up, and just, you look at it and have your staff look at it. You just randomly pull a chart and just look at it and see. Obviously, as the time goes on and you get more comfortable with this, it's going to get better. And it's just to make sure that you check off each step, and that you're, just following the guidelines for Medicare or whatever the insurance company is. So here's a dry eye potential in your practice. There are so many people out there with dry eye. And we say here, average practice is seeing about 3,000 patients a year. And then, overall 25%. So let's say about 775. Average reimbursement here in the US is $73. So you take this and whatever it is in your country, whatever you think it is. I'm not familiar with other countries. I apologize. But we do here, drops, follow-up visits, punctal plugs, reimbursements. And this is just no additional diagnostic testing. Okay, this is just revenue, plugs, follow-up visits. So potential from those 750 is almost about $200,000. And then you're keeping the patients for life, right? 30 years, let's say, out. It's a big increase in your practice from the dry eye model, and you're not doing any diagnostic. So you're keeping the patients in-house, and you're not telling them to go to the local pharmacy and get artificial tears, okay? You are explaining to them what they need specific to their eye. You are explaining where it comes from and why they need it. So, good case history and having them explain the follow-up visits, and then, knowing your insurance plans, what's covered, what's not. And a lot of patients will say, my eyes are red, they're tired, they feel like they don't know what it is or so, and the dry, sandy sensation. And you just explain to them what it is, or if they have excess tearing, you explain to them why. And now with COVID, computer vision syndrome, and then contact lens wearers, there is a big opportunity for you to address dry eye in your practice. So, to approach it, you can start by knowing your insurances, like I've discussed. If you have EMR, by your codes how many patients in your practice that you've diagnosed, and then what the potential is. So you can determine what the potential income revenue would be. And it's the same thing if you have diabetics, if you want to introduce retinal photography into your practice, glaucoma suspects, visual fields. And so that is something that, you'd have to be a little investigator, put your business hat on, and figure out what is the next step to grow your practice. And a lot of doctors are nervous because some of the diagnostic equipment is larger set price for your practice, but the revenue potential, the long-term potential, you make it up right away. And it differentiates your practice too than from the practice down the street. So some action points, you recognize it, you ask the right questions to the patient, and then you let them know what your findings are. And obviously a lot of people know what the symptoms are. So, burning sensation, achy sensations, heavy eyes, dry, photophobia, watery eyes. And then, can cause from, computer use, aging, medications, some eyelid issues. And I explained to them what layer of the tear film we're looking at and why and what the treatment is for that besides just artificial tears over the counter. As you know, the lipid layer prevents tear film evaporation. Aqueous layer contains water and nutrients, and the mucus layer spreads tear film evenly over the eye. So some people have had dry eye has had a correlation between anxiety and depression, and you need to evaluate the signs. So I've had a lot of patients that are on anxiety or medications, and I ask them and I probe for that, and they said, yeah, over the last 3 months I've had an increase in it. So ask those right questions, and then if you find there's a lot, then you invest in other technology as you grow. So besides, you do collagen plugs and artificial tears and pads for the eye, then you can invest in LipiFlow or TearLab and grow your practice. So here is the different types of dry eye issues and how they're treated. Obviously, once you explain to the patient whether it's hyperosmolarity, artificial tears, plugs, they have inflammation, you prescribe a drop. Here in the US, very popular is Xiidra, Restasis. The different layers and issues, and then how you treat it. So here are the typical visits. So you diagnose, you treat, you follow up. If it's not working, then you repeat it and you continue. So this is something to follow, and you have your own strategy and what you're comfortable with. So once you get these visits down in your head, whether it's dry eye, glaucoma, diabetic retinopathy, it's fast, it's efficient, and your staff members are doing this testing. You're coming in, you already know by just looking at the data what you're going to do next. So you can see more patients, and you're comfortable, and you're confident, and patients trust you. And then you want to properly document it, of course. Chief complaint symptoms, how it affects their daily lives, what unsuccessful has been, and and then also you want to back up your testing to show the next step in your treatment process, what worked, what didn't work, and what the future potential treatments will be. So you have a plan that if they follow up in 6 months and maybe punctal occlusion didn't work, what the next step would be in your treatment. So I have this in my waiting room, and so as patients are waiting, they know. So then it's also it causes a conversation when they come in. They say, no, doc, I looked at this, and I've been experiencing this, or my sister has this. And it opens up a conversation to go through the medical model that way. And then you market your services. You want to market it. You want to let everybody know about it. Educate your patients. Facebook has been great to advertise my practice. I have collect everyone's email. We do back to school campaign now with myopia management in my practice. We're targeting the schools that we can. We're doing emails, pediatricians, nurses to let them know about it. And then obviously when patients come in, we let them know about the latest technology in our practice. And then if we add, new testing for our practice for diabetics or glaucoma, we would send out letters to local physicians to let them know that they can, send their patients to us, and they'll get the highest quality of care. So we went through dry eye. Glaucoma is great as well, even if you don't treat, because you're working them up until a point where you notice that they need treatment. You might need to refer them out. But if you see here, it's about 120,000 patients. About 12% can go blind from glaucoma. So it's a great opportunity for you to expand your practice, monitor your patients. If you notice a visual field defect, if you can't treat, to refer out. Images to show them over the last 5-6 years how their optic nerve changed, educate them. I think patient education is super important for the best outcomes. I know for like retinal issues like holes, tears, if they're high myope, I always educate them. I say, this could happen. If they're educated on it, they're not going to wait and say, my eye was blurry for the last 2 weeks and now I'm coming to see you. If they notice problems sooner, we can get them to see a specialist quickly, and the outcome's a lot better. So again, this is super important that patients understand, and what you're doing, why you're doing it, and that they know how important it is for them to seek care right away. And education is super important for these patients for best outcomes. And cataracts are something that a lot of patients will ask about, and a lot of you know these, but cloud, blurred vision, increased difficulty at night, seeing halos, doubling of vision in a single eye. These are all important things that patients will ask about, and it's your job to explain to them and what the next steps are, and whether it's corrective lenses, monitoring, or surgery. So cataracts can be more than just as you age, but diabetic patients get it sooner. Trauma, hereditary diseases, smoking, alcoholism. These are things. So you get some patients that are younger and they want to know why. They think it's a disease of a patient that's 80 years old. And we say, well, have you been smoking over the years? Did you not wear sunglasses when you were younger? These are all important things. Or even some medications. We know that patients that are taking steroids at higher risk. And then, here are some other ones with systemic diseases. Looks like with the more is posterior subcapsular, comes more with systemic diseases. So if you notice a patient that's younger, let's say, has posterior subcapsular cataract, you might want to, talk with their PCP and see if, get some testing to see if they have any other issues. Again, you do a case history. Obviously, visual acuity is important. Contrast sensitivity, glare testing. They get a lot of glare, but their vision's still almost 20/20. That impairs their vision tremendously, and you explain to them why. So you see here the posterior subcapsular cataract. Light comes in. If their pupil's small, then it can shatter onto the retina and get a lot of glare. It distorts their vision. So it's good to explain to that. And let them know what the next steps would be. And then grading the cataracts is important. Nuclear, it's mild, moderate, pronounced, severe. Cortical, it just depends on what percentage it's taking up. So, up to 50% second grade, 50 to 90 is third. And then posterior subcapillary, 30 to 50 is second and third. Here's another thing with nutraceuticals that's important that we can reiterate. With cataracts, the Beaver Dam study showed that antioxidant properties with C and E, carotenoids, lutein, and zeaxanthin are important for the eye, but they're also linked to cataracts. So that might be something that you tell your younger patients about if they're worried about getting cataracts sooner. And cataracts are not as sight threatening, let's say, as glaucoma or macular degeneration, but it's very common. So patients want to know about it. It can be solved, obviously, with surgery, but some patients don't like surgery. So it's important to give them options and say, look, if these are the studies out there, this is what you need to do. Follow-up visit exams are important. Sunglasses will help kind of slow down the progression, but genetics have a lot to play with it too as well. So evaluating the cataract, the opacity is the embryonic nucleus. That's the nuclear cataract. We see brunescence in the eye. And then obviously the high molecular weight particles scatter light. So it causes patients to have color vision changes, glare, diplopia, reduced vision. So here is what NCS would look like, which many of you are familiar with. And then the posterior subcapsular cataract, loss of lens fiber in the nuclei. So these cells are forming balloon cells, and they're breaking down and causes this this cataract in the posterior pole. You know, the other important thing is low vitamin D can be associated with PSC. So we would see this on retro here, the back, which many of you are familiar with. And cortical cataracts, okay? So usually bilateral, they're often asymmetric, and sometimes they can affect the visual axis and they'll be off to the side, but you get a lot of glare and from that, and patients have monocular diplopia. So here's an image of that as well. Again, that's low grade. So we'll go into a case study here. We have a 43-year-old male with blurry vision. History normal, as patient has blurry distance vision, and at night that's getting worse on the left. You know, family medical history, Crohn's disease, and been taking prednisone. His family father had cataracts, and he was a smoker. You can see here in the right eye, it's 20/60 vision, best corrected. And the left eye was 20/40, best corrected, and the left eye continued to stay at 20/40. Glare testing made it a little worse. Pressures were normal, pupils were normal. And then in the slit lamp examination, noticed a central opacity in the posterior aspect of the lens. And the dilated eye exam was normal. So you can see here that this patient, because of the medication he was taking, had a posterior subcapsular cataract. So you would educate them on the steroid and refer them for surgery because their vision was best corrected 20/40. But you would also recommend that they follow up in a year for a dilated eye exam. Just because their problem has been solved, and it's not just vision. You're, again, referring back to let the patient know it's the same, you know, health. It's a health check. It's not just because their vision's been solved. They don't need to see you. It's the same thing I say to patients that have LASIK. We say you're 20/20, but your retina is still a -6. You still risk at retinal detachment. Other issues. You still need to be seen. So again, you continue that communication and you let them know that it's still not just refractive. We have here a case study. 75-year-old with blurry vision, and it gets worse at night. He's diabetic. His A1C is 12. He's taking insulin. Family history, cataracts and glaucoma. We would educate him on that, and then his diabetes as well. His vision coming in uncorrected was 20/50. Best corrected got him down better to 20/30 in the right, 20/50 in the left. His pressures were 21 and 20. And then pupils were normal, fields were normal. Slit lamp, we noticed that there was some clouding in the lens, greater in the left eye than the right. And dilated fundus exam, we noticed that things were normal. Cupping was about 45 in OU. So when we take a look with the slit lamp, we noticed a snowflake cataract, you know, which is common sometimes in diabetics. as we know with diabetics, the pathway here from glucose sorbitol and then the swelling of the lens. So I'll tell my patients, diabetics get cataracts much sooner with the spikes in sugar. It kind of swells the lens. So diabetics get it much sooner. So you kind of stress the importance of that to kind of keep sugar low. And, it's instead of just retinopathy as well, but also lens changes and everything else. So we would recommend that, he have surgery for that and, treat his diabetic retinopathy and also have him back for, because he was a suspect because of high IOP and family history. So that's important to consider photos, visual field, and OCT. So these are just some common things that we would see in our practice: cataracts, dry eye, diabetic retinopathy. But there's a lot of things that we can do to grow our practice medically and continue to serve our patients at the highest level. I know we went kind of fast, but if there's any questions.
Thank you very much, Dr. Maria. I think it was very comprehensive and a lot of information which you have shared. A lot of people know about all this. We definitely know as optometrists, but I think your ideas on sharing how to put it across into our practice now is now a question. So thank you for enlightening us with this very comprehensive talk.
Thank you.
Yeah, I just wanted to discuss about the point where you did mention that the medical model is kind of the model which we should follow, that does not increase your chair time. I think that's the point you did mention, which is really important for us to understand, because we feel that if we do additional tests in our practice, people usually feel that you're going to take more time and you're going to have less patients in a day. That's a problem. So I think that you made it very clear that it's not going to take time. It's just that you will have to do it a problem-based kind of a thing. So yeah.
Yeah, it's a problem-based visit, but you're also training your staff, right? So the staff is doing that, the visual fields, they're doing the testing, and you're seeing another patient, and then your 5-minute visit to come and evaluate. And the more you do it, the more confident you are, and you already have your how you're going to treat them and what your follow-up visits are.
That's right.
So it does not take a lot of time. But if you think in the long term with those patients over 30 years, it grows your practice, referrals, and differentiates yourself from others.
That's right. And I think now, because of COVID situation, we want to spend the lesser the time during the practice, as well as do the maximum test for our patients. So I think the medical model and the problem-based kind of a thing is the way to go, I guess.
That's correct.
Yeah. Somebody does mention that the ideas of putting the brochures in the waiting hall is a great idea, so that the patients are aware, it briefs.
Thank you so much. Yeah, it's a good conversation starter. So it's something that some people don't feel like they need to ask sometimes. They forget to ask. But again, you want to let them know that you're their eye care expert for everything. So I think that's important.
Yeah. And do you normally practice in terms of teleoptometry now due to COVID? It's just out of this thing. Do you do teleophthalmology, teleoptometry? And
yeah, so at the beginning when we were on lockdown here, did a little bit, mostly, but it was mostly like my older patients. So they're just not computer savvy, so we did some stuff via phone that we can handle. If they were having retinal issues, then you have to go in. So we'd go in, but I didn't have a lot of them. Other optometrists here have done that if they have bigger practices or so. But most of the stuff was via phone, and then most of them was just reordering contacts and things like that. So if they needed to come in during COVID because it was essential care, I would go in, and it would just be like that one patient who would take the precautions. So, and what the good thing is in the industry, a lot of companies came together to work with optometrists to provide them, information, and also, PPE. So that was great. A lot of companies gave doctors, equipment for slit lamps, to protect themselves and their patients, and masks and things like that. So that was a great thing to come together.
Yeah. And one more important point I think I wish to highlight here, that you did mention that sunglasses, even you put it as across as a medical device to your patients, that they must understand the use of sunglasses. I think most practices or most patients, to be honest, doesn't know that sunglasses, wearing a proper sunglass, I should emphasize on the word proper, sunglasses are really important. So that's very important when you're talking to your patients. You must make sure that they understand even that small thing, which is just sunglasses. People just wear it for fashion nowadays, is actually a medical device, right?
That's right. Yeah. So, the retailers are going to say it's a fashion device, it's a commodity, but you need to explain to them. So it's the same thing as anything else within your office. They need to wear sunglasses to, prevent cataracts, for AMD. They need to understand. They need to understand the difference between polarization and other things to protect their eyes. So it, again, comes back to the doctor. I can't stress it enough for the doctors telling them how important it is, and communicating with the patients. If they're getting all their information from online or commercials and you're not educating them, you lose. So
Yeah, that's right. And now everything is available on Google, so patients are very ready to know their questions online. So I think it should come from an eye
from you,
doctor.
yeah,
Yes.
not Dr. Google. And sometimes there'll be some information from companies that that are trying to sell a product. So you get a lot of these blue light filter glasses now on Instagram and Facebook and things like that. Some of them are following qualifications, others are not. So you just need to make sure you educate your patients, even if it's something like in a newsletter or something like that, just so they know, and they know why your office might be a little more pricey than online or something like that, so they understand, so they don't think that you're overcharging them. So
Yeah. Okay, there are a couple of questions here. I think this is an interesting one, because there is always a debate going on between ophthalmologists and optometrists. Good question here when it comes to, when you practice it as a medical model, where, I mean, definitely in the US, you are able to diagnose and treat certain eye conditions, as you mentioned. Would there be any conflict of interest between your practice and the ophthalmological practice? And if there is,
sure.
how do you overcome it? Is there any tips you would like to give us?
Yeah, I mean, sure, of course, right? So there might be some things with ophthalmology practice. There might be some things with optician practices too, right? So, you just have to find that fine line and have a good relationship. And you tell them, say, look, I have these patients, and when I don't, they want to do surgery, right? Most of the times. Try to have a good relationship with who I refer to. If they don't like my services and optometry friendly, I don't refer to them, right? And a lot of ophthalmologists now understand what optometrists can do and value them. So you have a few that you would call up and say, look, I have this suspect. I'm thinking that almost ready to be sent out. What do you think? You keep that dialogue. Yeah, but you're going to get some conflict of interest sometimes. And same thing with, retail shops that, it's just selling glasses, and you're selling glasses too, but they don't have a doctor. So you try to figure out a way to work together. So I would sometimes call some offices and say, look, you guys don't have a doctor. I'm happy to see, the patients. And sometimes they would refer the patients, and maybe they might get glasses somewhere else, but we're trying to convert them as long-term patients. So it's kind of trying to figure out how to work together. I always say the smart business people work with their competitors. They find ways to work together.
I think I read this sentence on your corporate optometry page somewhere. I remember this quote, that smart people work with their competitors. That
Oh,
helps.
yeah, there's an article out there, Working Competitors. Yeah, it's on the corporateoptometry.com. Yeah. It's just an outside the box thinking and on how to do it.
That's right. That's right. And we have another question. This is kind of a clinical, but maybe you could just give us some, details or ideas about it. This is regarding a patient, which is, I think, one of your case studies. if let's say the patient had cataract and diabetic retinopathy, how would you go about? Do you want to, refer them to the diabetic retinopathy treatment, or you would want to proceed them with cataract? I think this question rolls around when you want to do kind of a referral. Where do you want to refer first? Probably that's the idea.
Yeah, I mean, it all depends on how bad the diabetic retinopathy is. If it's like dot hemes, then you probably need to refer for cataracts. But if it's advanced, then obviously they need to solve that first, right? But if the cataracts are mature and the retina specialist can't get a view, I think it's case specific. So, and then if you have good relationship with your cataract surgeon and your retina person, you can kind of collaborate with them, right? So the smart ophthalmologists, back to the first question, want to work with optometrists so they get their referrals. That's, a lot of patients aren't going primary care to the ophthalmologist, right? And the ophthalmologist that are retina or glaucoma, they don't want to see the routine stuff. So if the smart practitioners will work with their competitors in a sense for the ultimate goal of what they want to do. So, and I think this question is a great question. It just depends on the type of retinopathy and advancement. So again, it's up to the doctor. So it's your call. But if you feel uncomfortable, you would talk with your partners.
Okay. And just connecting question with this, how do you normally explain to the patient if you would want to give this kind of, doing the counseling for the patients who have cataract and diabetes both? So again, you would definitely take the severity of the disease into consideration, right? But is there anything you would like to focus on mentioning to them in terms of having two conditions at the same time?
Sure. So, retinal photography is a great tool for that. So I would show them. And then, sometimes if the cataract's advanced, the image is blurry. So on the retinal camera. So I would say to them, look, this is as good as you can see out is the good I can see in. I do see some retinopathy. I don't see any neovascularization or anything like that. But, maybe, once we get the cataracts done, then we'll get a better look at the retina. But, there's retinopathy, you need to keep your sugars low.
That's right. Yeah. So I think having that equipment, the basic things, and, explaining to your patients based on the results of your examination plays a vital role, I guess.
That's correct.
Yeah. And let's just take one last question. I'm reading up one question on the chat which catches my attraction. Would you want to tell us about the work of practice in terms of orthoptists? If you have any, I'm not too sure whether US has a specific, classification of orthoptists versus the ophthalmic nurses compared to optometry. Do they gel along, or how's the scope of practice there, if there is any?
So when I graduated in 2007, my first job was at a pediatric ophthalmology office, and they had an orthoptist there. That's the only time I've worked with somebody, but she was from the UK. It's not very common here. Usually we just have like techs and we train them and things like that. But, maybe I can learn more from you guys on that. So.
Yeah. Okay. And anything about ophthalmic nurses? Is there any specific classification of job profile in ophthalmic nurses kind of a thing?
Yeah, we just say ophthalmic techs here is the thing. So they'll go through a training. They'll have a test to take. Some doctors will just train the staff as well. But if you go to like the conferences here, they have specific training for ophthalmic techs. And then, they're super important in your practice. They're doing a lot of the heavy lifting in your practice, and they're talking to the patient more often than you are throughout the year. If the patient's calling back for contacts, issues with their glasses, they need to be educated on it. And they're also like the pulse. They know what issues your patients have, what patients like. So going back to, those team huddles, those are important. So your patients are, you're informed, and then you can better serve your patients.
Yeah. And do patients really know the difference between the different occupations like optometrists, ophthalmic nurses, and all that? Any comments on that?
Yeah, unfortunately, I think they don't. So sometimes here in the U.S., they might confuse us with opticians. You know, it's and then as we know, like sometimes they might not think optometrists are you know, doctors. So again, it just goes back to optometry, advocating for optometry, you know. So that's one of the things with this group, that, you know, trying to bring optometrists together all over the world to kind of advance optometry. I know here we have pretty good scope, but, you know, things are going to change, and hopefully, you know, in the US, doctors can ban and help doctors in India. I know Greece has, you know, they're basically opticians, and they can refract, but they know they can do a lot more. So trying to, you know, work with them. The UK has other things. There's been changes. I've talked to doctors in Australia that work at Specsavers and things like that. So, you know, we need to come together as a profession to help, and it's not, you know, the retail optometrist versus the private, or we need to work together to, you know, for best patient care, but also because we're educated enough. And I think in the future, some data here in the US said that there won't be enough ophthalmologists. So what do we do to best serve our patients? You know, so if stuff that can be preventable in blindness and vision loss. So I think that's important.
That's right. Yeah. I think that covers a lot of aspects, and I think that's almost answering to most of the questions on the chat. So thank you very much, Dr. Maria, once again for, you know, enlightening us, and you know, I think it's kind of guiding us to this path on starting optometry practice, not only like just doing refractions and selling spectacles, but you must go ahead and do the primary eye care, as we know in this part of the world, to do your primary eye care and get your patients to that best care what you can provide within your scope. So thank you very much once again.
Thank you so much for having me. It's a pleasure. And
Yeah.
I look forward to connecting with people on the internet, so on Facebook. So
Surely.
feel free to join.
Yes, yes. So I would highly recommend people to, you know, just visit the page, and there is loads of information being shared, you know, every day. A lot of posts, people sharing, commenting, and it's really interesting to see on what people think in different parts of the world, how optometry is. And it gives a very good idea on how you can tune in as an optometrist, how you can fine tune your skills to cater to your patients.
Thank you.
A quick reminder that we are also in a process of having case presentation series for optometry students as well as practitioners. So those who have interesting cases, like some case you saw today, Dr. Maria did present 2 case studies kind of a thing, which she has seen in her practice. So something like this, a bit of unique cases or interesting cases, if you have seen in your practice and you would wish to present onto our platform, we would welcome you. We request you to submit your abstracts so that we could get it through the scientific committee, and we would schedule your presentation, and you can share the patient's case presentation onto our platform. We do have sessions next week. Yeah, so this brings us to the end of the session for today, for this weekend. Thank you everyone for joining in, and I wish you all to stay safe. Take care, and I'll see you again next week. Until then, bye-bye. Take care.
Thank you. Bye-bye.
Bye-bye.